Good evening, everybody. Today we are going to discuss about a very important topic, that is ABG analysis. So first of all, how to take a sample. When you take a sample, take a syringe of around 2 to 3 ml. Take a small syringe. Along with that, apparenize the syringe. And now, when you are going to collect a sample, always collect in a, always hold the needle, hold the syringe in a pinholing fashion, and puncture the artery, that is radial artery or the femoral artery, at an angle of 45 degrees. Got it? You can see it from the picture. So how to apparenize the syringe? Heparin should be taken in the syringe to lubricate the inner wall of the syringe, and then the heparin should be expelled from the syringe completely. So take 0.05 ml of heparin and lubricate the whole inner wall of the syringe and then expel it out completely. Okay, it is preferred to use a low concentration heparin. That is, sample the heparin where 1 ml of heparin contains 1 ml of 1 ml contains 1000 international units of heparin. And when you take a sample, you also have to be aware whether you have pulled in air from the atmosphere, because if you pull in air, there will be errors in the report. The PaO2 and PCO2 will be erroneous. So it is always important to check whether there is air in the sample. If there is air in the sample, expel it out. Okay, and it is also important to go, when you take the sample, immediately go and do the reading. Don't hold it for long, because if you hold it for long, again the report will be erroneous. And if you happen that you have to hold it for long, in that case you have to keep it in a ice cold temperature. Okay. Next, what are the ABG and VBC normal values? Normal pH of arterial blood is 7.35 to 7.45. For calculation purpose, we take a 7.4 normal. And venous 7.31 to 7.41. What is the value of PaO2? It is 80 to 100 millimeter mercury. And venous 35 to 40 millimeter mercury. And PaCO2 35 to 45 millimeter mercury. For calculation purpose, we take 40 as normal. And for venous 41 to 50 millimeter mercury, and bicarbonate 22 to 24 millicarbonate per liter. For calculation purpose, we take S 24 as normal. In venous, the same. Oxygen saturation 95 to 100% normal. In venous 68 to 77% normal. So it is very important, you have to remember these values, then only you can read an ABC. And also then only you can differentiate whether it is an arterial sample or it is a venous sample. Okay, you have to remember this value, it's very important. Next, when you have an ABC in your hand, you have to check three things, that is the oxygenation status, ventilation status, and the acid base status. Or when you have to check the oxygenation status, look into the PaO2 and the FiO2 ratio. That is, PaO2 you will get in the ABG. Suppose you got ABG 60, the PaO2, and the FiO2, how much FiO2 you are giving? If it is a room air, you are giving 0.21. Okay, 21% FiO2. So 60 divided by 0.21 will be 400. So will be around 300. So normal value is 400 to 500. So if it is less than 400. So the blood sample is hypoxemic. Correct? But if the PO2 value is suppose 80 and FiO2 is in the room air, it is 0.21%. So 80 divided by 0.21, it will be around 400. So normal value we know it is 400 to 500. Okay, so it is normal. Ventilation status, whether the patient is hyperventilating or hyperventilating, that is breathing more or breathing less. Okay, so in that case you just see the CO2. If the CO2 is less, then patient is hyperventilating. If the CO2 is hyperventilating, if the CO2 is high, then patient is hyperventilating. High CO2, hypoventilation. Low CO2, hyperventilation. Okay, got it? Then you come into the acid base status. Acid base status, you have to see whether there is acidosis or whether there is alkalosis in the sample. To see that, first look into the pH. The pH, normal pH is 7.4. I have told you, for the calculation purpose, take it as 7.4. So if it is less than 7.4, it is acidosis. If it is more than 7.4, it is alkalosis. That is just that simple. Okay. Now you have to see whether why there is acidosis or why there is alkalosis. Okay. So if acidosis, you have to see whether it is respiratory acidosis or it is because of the respiration, or whether it is metabolic acidosis or it is because of certain metabolic problem. Okay. Or whether it is respiratory alkalosis. If it is alkalosis more than 7.5 4, whether it is respiratory alkalosis problem or it is metabolic alkalosis problem. Okay. So how to do that? So for that, you have to check just only two values, that is the CO2 and bicarbonate. So if if the suppose for example, if the pH is less than 7.4, that is 7.2, and you have to check whether the what you have to check the carbon dioxide and bicarbonate as I told. So now if the carbon dioxide is more than 40, that is 50 suppose for example, and the bicarbonate is normal or high, in that case what is going with the pH? pH I have already told it is acidotic 7.2, and the CO2 is building up, that is also acidotic. So here the sample is respiratory acidosis. It is not going with the bicarbonate, it is going with the carbon dioxide. So you have to match it, just matches with the pH. Okay. So along with that, there is always a compensation. So if there is respiratory problem, the kidney will compensate by conserving or excreting bicarbonate. And if there is metabolic problem, the lung will compensate by retaining or blowing off the carbon dioxide. Got it? So if the pH is, you have to remember this. If the pH is 7.4, that is normal. If the pH is less than 7.4, it is acidosis. And if the CO2 is high, then it is respiratory acidosis. Got it? But along with that, there will be compensatory. Bicarbonate will also be high. That is compensatory. That is, the body is trying to compensate. But the main problem is respiratory acidosis. Along with that, there is compensatory metabolic alkalosis. Okay. But if the pH is more than 7.4, that is alkalosis, and the PCO2 is less, that is less than 40, suppose 30, and the bicarbonate is also less. In that case, you will see the pH is matching with the carbon dioxide, because the pH is 7.5, alkalosis I have told it, and the carbon dioxide is less, that is respiratory alkalosis. So here the pH is going with the CO2. So it is primary respiratory alkalosis. Okay, along with that, there is compensatory bicarbonate will be less, compensatory metabolic acidosis. The same way, in another case, if the pH is less, you have to again see the CO2 and bicarbonate. pH is less or pH is high, whatever. Next, see the CO2 or bicarbonate. If the CO2 is less, that is acidotic, CO2 is less, but bicarbonate is also less, then in that case, pH is going with the bicarbonate. So it is a metabolic acidosis primary problem. Along with that, there will be compensatory respiratory alkalosis, for which the CO2 will come down. In the same way, if the pH is high, suppose more than 7.4, it is 7.5, and again you are seeing the PCO2 or bicarbonate, which way it is going. PCO2 is building up high and bicarbonate is also high. So if the PCO2 is high, that is acidosis. It is not matching with the pH. But if the bicarbonate is high, that is alkalosis. Yes, it is matching with the pH. So it is primary problem is metabolic alkalosis. Along with that, there is compensatory respiratory acidosis. Because of that, we see this. So what are the causes? Causes of respiratory acidosis, for example, COPD, asthma, pulmonary edema. Causes of respiratory alkalosis are like in anxiety, when the patient is in fever, in sepsis, in pregnancy. Some causes of metabolic acidosis are like acute and chronic renal failure, we get metabolic acidosis. Severe diarrhea, alcoholism, we get metabolic acidosis. Then metabolic alkalosis, when the patient is vomiting, it is loss of acid, vomiting, gastric suctioning. In that case, metabolic alkalosis we might get. Or the patient is in long-term diuretics therapy, this patient is on Lasix, or excessive patient is getting excessive bicarbonate from the outside, and also we get metabolic alkalosis. So these are just few causes of respiratory acidosis, metabolic acidosis, alkalosis, but there are many other causes, and you need to remember some. Okay, so let us see some example. So we have a 60 years old male, known case of COPD, with presented with respiratory distress. So his ABG is showing pH is 7.3. So it is acidotic. Yes, less than 7.4. Now you see the bicarbonate and CO2. So CO2 is here 60, that is high, and bicarbonate is also high, that is alkalosis. So CO2 is in the acidic size, that is 60. So pH is also less than 7.4, that is also acidotic. So the primary problem is respiratory acidosis. Along with that, there is compensatory metabolic alkalosis. Okay, and the PO2 is also less, so patient is also having hypoxemia. Next, we have another case of 24 years old male presented with several episodes of dose 2. Again, we did an ABG. We found that the pH is again less, 7.2. So this is also acidosis. So again, we will see the CO2 and bicarbonate. So here bicarbonate is less than 24. So it is going towards the acidotic side, right? But PCO2 is high. It is PCO2 is also less. It is going towards the alkalotic side. So the pH is matching with the bicarbonate. So it is primary problem is metabolic acidosis. Along with that, there is respiratory alkalosis. Got it? So the and the PO2 is 88. It is normal. So oxidation status is normal. Next, a 45 years old female presented with high grade fever since last 2 days. Here we did an ABG. We found his pH is 7.5. So it is going towards the alkalotic side. It's more than 7.4. Okay, now again see the CO2 or bicarbonate. The CO2 is less. That is CO2 is going towards the alkalotic side, that is respiratory alkalosis. But bicarbonate is also less, it is acidotic side. But the pH is showing alkalosis. So the primary problem is here respiratory alkalosis. Along with that, there is metabolic acidosis, which is compensatory, right? And then the PO2 is 82, so it is normal. So it is hypoxia. In room air, it is normal. So patient is not having any hypoxemia. Lastly, another case, a 65 years old female presented to us with multiple episodes of vomiting. Again, we did an IBC. We found that the pH is 7.55. So again, it is more than 7.4. So it is alkalosis. Got it? Okay. Now we have to see whether it is respiratory alkalosis or metabolic alkalosis. In that case, look into the bicarbonate and the CO2. So if the bicarbonate is high, here the bicarbonate is 34, more than 24. So it is going towards the alkalosis side. And the CO2 is also high, 48, but it is going towards the acidotic side, that is respiratory acidosis. But we have the pH is 7.5, alkalosis. So the pH and the bicarbonate are matching. So the primary problem is metabolic alkalosis here. And along with that, we have a compensatory respiratory acidosis. And if you see the PO2 is a 68. In room air, PO2 68. So if you do the PO to FI ratio, it is 68 divided by 0.2. So it will be less than 400. We say that 400 to 500 is normal, PO to FI ratio less than 400. So patient is hypoxemic. Got it? So I have given 4 examples to make you understand. See, for an ABG to read an ABG efficiently, you need to first of all remember the normal values, and you have to practice. If you keep on practicing with the ABGs every day, practice one ABG, then you will definitely come out with a solution. So practice every day. That is very important. Okay. Thank you.